Hiroyuki Daida with Mike Gibson, and we're talking about omega fatty acids and cardiovascular disease. Obviously, a lot of controversy out there with the divergent results between REDUCE-IT and STRENGTH. And here you are with a study from Japan. You kind of led the way with the JELIS study many years ago, back in 2005, with a lower dose of the EPA. But now you've come back and done a study again, the RESPECT-EPA trial. And you used a dose of 1.8 grams a day, a little lower than what we used in REDUCE-IT, which was 4 grams a day. And you enrolled people who at baseline had a little low EPA, less than 0.4, right? So they were at risk. And these were chronic CAD patients on statins. Interestingly enough, you came really close on the primary endpoint of, death, MI, stroke, urgent revasc, P of 0.055 there, but on sudden death, MI, stroke, P of 0.03, with a good absolute risk reduction, about 3%. I thought it was interesting, you had a higher rate of atrial fibrillation, just like we saw in REDUCE-IT. So it kind of confirms that.
That's right.
So, what do you say? I mean, no difference in mortality, but you're underpowered. So does this confirm or substantiate the results of REDUCE-IT?
Yes, I think that this result of the RESPECT-EPA is really consistent with the result of JELIS and REDUCE-IT. We perhaps support those results of the effect of highly impaired EPA.
And this study was done in Japan. I go to Japan a lot. You eat a lot of fish. You have higher EPA levels at baseline. So you used a little lower dose of EPA than what we use in our country. So it seems to substantiate the idea that EPA itself is mediating some of the benefits. And REDUCE-IT, of course, we saw a relationship between EPA levels and outcomes. Did you see a relationship between EPA levels and outcomes?
Yeah, actually, that we did the post-hoc analysis. If we exclude the patient whose EPA increased by greater than 30 microgram from the control group, and if we exclude the patients whose EPA did not increase greater than 30.
In the treated group?
Yeah, in the treated group. The difference between the two groups in terms of the primary endpoint become significant. And
which again points to the causal role of the EPA, correct?
That's right, that's correct. Yeah.
And the mechanism, we think it's working by changing oxidized LDL. Is that the current thinking about the mechanism of benefit of EPA?
Oh, it's a little bit difficult to make certain decision for the mechanism because the EPA has a lot of action. And I think that because it takes time to show that beneficial effect on the EPA, so perhaps this substance should be incorporated to the membrane or tissues. So,
and it looked like it took about a year for your outcomes to diverge. So, are we ready to use EPA in clinical practice more? Does this give us the second trial to substantiate benefit to use it in practice?
In Japan, that this drug is approved already. So we confirmed this effect in the current secondary prevention situation with the high-dose statin. So this is encouraging. Although we need to be careful about the atrial fibrillation.
Interesting. It was seen in both studies. So I would have thought it would be a membrane stabilizer and reduce atrial fibrillation. So I was, very surprised to see that.
That's right. We need to see the more mechanistic way of the atrial fibrillation.
Maybe we need to put Apple Watches on people to see if they're going to.
That's right.
Yeah. Dr. Daida, thank you for joining us.
Thank you very much.
Thanks to you for joining us here in the audience.